We are very excited to roll this out. It's been a lot of work and time in the making, and working with our team, and so we are really happy to be here today. So, a couple housekeeping items for everybody. I believe we have attempted to mute everyone as they came in. So, if you are not muted, please go ahead and do so, just to minimize the feedback as we're talking and presenting this concept. Again, we'll do our best to keep up with that. If you have a question, though, because if you've been on these roundtables, you'll know that we try to keep them as interactive as possible. We like to do less presenting and more conversing with everyone. So there's two kind of ways we can do that. As we're presenting and talking, feel free to post a chat message in the chat box. If you look in the main window and you go down to the bottom right, there's a little chat button that'll bring up the chat box. And you can select to send a message to everyone or just to the presenter. I'll be watching that, as well as Andrew on our team will be watching that, and we'll make sure to get those questions to Seth, as well as then at the end of the presentation, we will open it up for Q&A, and at that time, feel free to unmute, and we can take those questions that way as well. Otherwise, there is a couple different ways to do the video too. If you kind of scroll over where the video shows up on the screen, you can do grid view, which shows everybody, but I think a lot of folks don't have the video on, which is great. And then there's also active speaker video view, which will change the big screen to who is talking at that time. So that might be a good option, just to see who's talking. So really excited then to introduce a couple folks from our team that were integral in putting this whole Mary Lanning Regional Network together. And number one, we have Eric Barber, CEO of Mary Lanning Hospital, on the call with us today. He's going to be kind of walking through how Mary Lanning, the process of how we got here today. And I'd like to say we've been working on this for about a year with their team. I think Eric's had this vision for much longer than that. So it's been a work in progress for a long time. So we also have Seth Denson, who's our chief strategist on our team. And Seth will be walking through the intricacies of the network, how the network is built, and all those things. So with that, I'm going to kick it over to you, Seth, to kind of start out, and then we'll get it over to Eric, and then we'll talk through everything.
Thanks, Elliot. I appreciate it, and welcome everybody to this afternoon. You're going to see a smirk on Elliot's face, and that's because this is not the smooth, soul, raspy voice I wanted to be joining you with today. I actually woke up this morning with no voice. So I have been chugging a lot of herbal tea all day so that we could have this conversation and not have to reschedule. Now, this may be the best conversation of any roundtable we've done so far, because I'm not going to talk too much, because I quite frankly can't. But we're going to try to press through. So if I get that weird crackly voice that sounds like, what was it, Peter Brady in the Brady Bunch? I'm just aging myself there. I apologize in advance. But quickly, I'll turn the reins over to Eric Barber, and then you're in better hands with him anyway. What I want to do is lay the kind of the foundation for how this process went about, and really not only where we have been, but where we are, and then also where we are going. So if you've been on one of our roundtable discussions before, you will hear me constantly say, and all of our team at Ellerbrock-Norris say, that we speak to business leaders around not just Nebraska, but throughout the country quite often. And to almost the company, when we ask them what their end goals are, we can really boil it down to one of two things. They want to reduce and or better manage their costs, and they want to provide better benefits to their employees. That is at the core of everything. Now, interestingly enough, many employers have been sold a little bit of a bill of goods as how you get to that first piece, which is control your costs. And a lot of times we think that means shopping insurance companies. I believe that insurance can be the largest barrier to healthcare and the largest creator of costs because of the administrative overhead and the number of hands in the cookie jar. And so when we set out to build what we will be rolling out today, we set out on this journey with Eric in alignment with the hospital to say, how can we improve the healthcare access to our community while simultaneously creating a platform that puts the employer, Mary Lanning, on the same page. And that's what we've done. and big appreciation to the entire staff at Mary Lanning. I know Eric will be talking here in a minute, but I will tell you, this was a team effort. We've had no less than, I gotta say at this point, 100 meetings probably over the past year. And that's, no, I'm serious, 100 meetings in conversations over every detail. Now, if you've been in our roundtables before, we talk oftentimes about the value of controlling cost, that the only way to really control cost is to do one of two things. You control the number of claims that your people consume or the price of those claims. It's not Blue Cross versus Cigna versus Aetna versus United Healthcare. And quite frankly, it's not versus Mary Lanning Regional Network. You, as an employer, must understand where your costs are coming from so that you, in turn, can better manage your healthcare supply chain. Now, if we break down the vast majority of costs in the United States, they are comprised about 90% of them by 10% of the population. So 90% of all costs are typically generated by 10% of the population. Now, we spend a lot of time in the insurance industry talking about things like wellness programs and preventative care and all these other things, and these are all solid things. But the reason those things are so important is to reduce the number of your 10% of employees. And so as we start to think about how do we solve for the healthcare challenges that we have, we really need to solve for 10%. And that's going to yield a big return. And that really comes to what we call the managing the frequency and severity of claims. How do you do that? Well, you understand where your costs are. You understand how can we get ahead of these costs better. And oftentimes we will talk about you need to drive your car going forward down the highway versus backwards, where you've only realized that you've been hit until after you've passed that which you got hit by. And so a massive piece to this puzzle that we have built out with Mary Lanning is an engagement. We oftentimes refer to healthcare, sadly, in our society as the milk in the back of the grocery store, in that we have made it more difficult for employees to access care, for members to get care. And that MRI that doesn't get received, that physical therapy that isn't received, that diabetic that isn't properly managed, that becomes later a catastrophic claim. And that's what spirals our healthcare system out of control. So when we launched this platform, it was with the idea that we would secure the best contracts, the best in pricing, the best in access and engagement and data analytics and data for you to roll out. And I'm pleased that we've done that. And by no means has this happened and would not have happened without the commitment of Eric Barber. And so, Eric, I want to invite you to say a few words and welcome to the call and thank you.
All right. Thank you, Seth. Hopefully you get to feeling better. I don't know if you not being able to talk is good or bad, but there's probably varying opinions on this call. So
true.
Yeah, thank you. I was trying to remember. So Bruce Cutright, who's our vice president of human resources, I think he and I had a discussion about this concept or this idea probably 6 years ago, and wanted to find a way to make it into a reality. And yeah, I think it took that much time for multiple reasons. But if you look at Mary Lanning Healthcare, the way that it is now and the way that it was 6 years ago, we're a much different system. We are more comprehensive when it comes to specialty care. We're just a larger organization in general. And as you look across the landscape that is central Nebraska, I mean, it's true for the country, but just thinking about our our regional market, insurance isn't what it used to be either. Most of the employers now, if they're able, are going self-insured or self-funded. So we are the insurance company. Mary Lanning is no exception to that. When I got here 7 years ago, we were spending about, $9 or $10 million a year on our own domestic claims for our own employees, for our own 4,000 covered lives. That's approaching 18 million this year. So, there's been a lot of talk about flattening the curve this year, right? Well, what about the spending curve that is healthcare? It's unsustainable. And so we recognize as a hospital that we are the milk in the back of the grocery store. And we have to be part of the solution because we are part of the problem. And so where I think we wanted to go all along was creating transparency between the folks who are now writing the check for the care and the folks who are delivering the care. So that's the employers and the healthcare system, which includes the physicians and the hospital and everybody else. So when we say direct to employer, what I mean is I want to try to create transparency so that at the end of a year, I can sit down with the CEO of a company and say, hey, you spent $10 million on your folks' healthcare last year, and here's where we think you have opportunity to maybe change the way you spend or change where you spend. Healthcare is competitive. We have competitors here, and they have already made an attempt to cut us out of their networks and try to go for a race to the bottom to provide the cheapest care. And I would tell you that we provide a higher level of quality, and I'd like to be able to do that at an affordable price, but I can't do that overnight. We have a payroll that's sneaking up on $87 million this year, and that money has to come from somewhere. It comes from the services we provide. So as we look at changing our revenue streams, we have to do so in a collaborative manner, which this direct to employer network will allow us to do. So we want to incentivize folks to seek care earlier and where it's appropriate to try to avoid some of those catastrophic claims. And we do have a comprehensive wellness program that we have in place here at Mary Lanning that we will be rolling out as part of this package. And so again, I think the key component there is working transparently and collaboratively with our local employers who are now, they have become the insurance companies because they're self-funded. And I think we can slow that unsustainable growth of the healthcare costs in the United States and do it here. The cool thing is we're just big enough to be cool, but we're also small enough to be nimble as a healthcare network. And we have friends in Lincoln and Omaha who can help us round out a statewide network. We have friends out as far west as North Platte or Scotts Bluff that would like to participate where it makes sense in planning this network as it goes. So really, as we roll this out now, it's just the beginning. This will continue to evolve as we go through, the next 3 to 5 to 10 years. And obviously there's a lot of external forces at play, like elections, for example, that could make it so that we made the right decision at the right time. If in fact the way that healthcare is reimbursed nationwide is changed or forced to change by the federal government, then we will have positioned ourselves for local and regional success as a result of this. So the timing could be really good. All right, I'm going to stop talking because it's supposed to be interactive. I could go on for hours here. So I'll turn it back to either Elliot or Seth, and you guys can field questions or whatever, comments.
Thanks, Eric. I appreciate that. Yeah, and Eric, you bring up a great point, and I think it's something that we need to make sure that we restate, is that this network encompasses not just Mary Lanning. And so we have been working for the better part of a year now, securing arrangements with multiple hospital systems throughout Nebraska to be part of this, with the idea that which Mary Lanning is doing, providing greater transparency, access, information, and best-in-class pricing, so too they would as well. And it was interesting when we would have these conversations, and by the way, these conversations are still ongoing, to hear the almost excitement in many of these hospital systems to do something different and unique than let's just slap Blue Cross or Cigna or Aetna on this and move forward. These hospitals are filled with great people that want to provide a higher level of care and a more direct access platform. So with that, I will introduce, and I don't know that they're on the call. I think they are, but they won't have to speak. But there was another piece to this puzzle that we had to bring in, and that was Consociate Health. So Ellerbrock-Norris and our team here, boots on the ground, thinking through the strategies of it from the insurance perspective, and of course, Eric and his great team at Mary Lanning. But we needed to understand the actual processing of claims and the management of claims. And we knew that there needed to be a line drawn there. And so we recruited Consociate Health to do this. Now, Consociate Health is one of the nation's leaders in direct-to-employer contracts and claims management. So they will actually serve as the claims administrator for this program. They are independent, and their responsibility is not to Mary Lanning, nor is it to Ellerbrock-Norris, but it's to you. It's to you, the employer. So that's who they will ultimately work for within this network capacity. And that's important because it does create an independent set of eyes looking at this and working in alignment with all of us for the greater good. And so what they have done in other parts of the country has been phenomenal, reducing costs significantly over time, reducing medical trend over time, increasing value to employees. All of these things we believe can be achievable. And these aren't achievable things that are 2, 3, 4 years down the road either. We believe that there is significant impact that can be made in 2021 with this program. As a matter of fact, we've recently done a number of analyses on some self-funded plans here in Hastings, where we have been able to identify, in many cases, hundreds of thousands of dollars that can be recouped if those claims were to happen again. And that's not just because of the contract language for Mary Lanning, but also through transparency and understanding how to get ahead of claims, but also the referral partner contracts that we have had and are still continuing to improve upon with our neighboring facilities. Now, I don't want to get too deep into the weeds as to all of the varying details. We would love the opportunity of a conversation with you independently to share with you exactly how this plan could work for you, because this is not a cookie cutter, one size fits all program. We will customize the network program to your organization. Now, there's two types of organizations here. There's those that have fewer than 50 enrolled employees and those that have more than 50 enrolled employees. And the reason I draw that distinction is because the underwriting structures will be different for both. If you're over 50 employees, then you are what's called experience rated. In other words, your rates are a derivative of your experience, your performance, your claims. And so whether you get claims data or not, we can pretty close determine where your claims fall based on your insurance networks, your plan designs, and your current premiums. If you're below 50 employees, that's a little tougher because your rates are not just based on your performance, but based on the entire state of Nebraska's community rated performance. And so there's some few extra steps that we will have and some more, we'll call it boilerplate programs that we have for under 50 enrolled employees. But if you have more than 50 employees, we can easily determine opportunity for you. And if you're a self-funded employer, at least one that gets data, I argue that all employers over 50 lives are self-funded. You're paying your claims whether you realize it or not. But even those folks that are self-funded, we can certainly do greater analysis of opportunity for you. Another key component, and this is outside of Mary Lanning, is what we're doing around prescription drugs. And again, if you've been on our roundtable discussions, you've heard all of the shenanigans that go on in the prescription drug world. And it's estimated that for every 100 employees, there's approximately $100,000 of waste in the prescription drug world. And we're finding that money each and every day. And so there's certainly opportunity to be had there. The idea behind the network, because we're streamlining it, because we're creating better access at better pricing, is that we want to create programs that improve deductibles, co-insurances, and co-pays for your employees. And so each of these plans will have tiered networks. And by tiered, I mean there will be a preferred network, which is obviously Mary Lanning, a second tier network, which is our referral partners, and then a third tier, which is a national network that will serve to wrap all outside, we'll call it conditions, that if you were traveling abroad outside of the state of Nebraska. And we partnered with Aetna and First Health for that. So there is a third tier network that if you were outside of Nebraska, you would certainly, you and your loved ones, be protected and your employees. And then, of course, Mary Lanning at tier 1 and tier 2. And the deductibles and co-insurances and co-pays will range based on those tiers. That's part of the agreements in getting these best pricing with our referral partners is we have to improve deductibles. Of all the analysis we have done thus far, and we've done a number of them, we have not found one employer that would not have benefited from this program. Benefited by not only pricing, but also access and information. And again, you're all business leaders and you all understand the importance of understanding your supply chains. Healthcare supply chain likely is the top 5 expenditure on your P&L. So it's important that you understand that as well. So I'm going to pause there. We're going to open it up for questions if you've got some. Feel free to chat them to us. If you want to unmute yourself, you can certainly do that as well. We've muted you. We just ask that after you've asked your question, you'll mute yourself back, as there can be a lot of voices that create echoing. We all, I'm sure, are getting used to this Zoom virtual world. I hope not. I hope we don't have to get used to it. But nonetheless, we want to open it up for questions there right at this time. Elliot, feel free to take the reins here.
Yeah, absolutely. We did not have any come through in the chat window. So just a reminder, that's in the bottom right-hand corner. There's a little chat button that you can click on that to bring up the chat window. But Seth, I'll we can be talking through as we hear some of those. Those that are self-funded on the call, are familiar with the term unbundling of your healthcare supply chain, where you're selecting your network, you're selecting your carrier, your reinsurance, and those though that may not be as familiar with that, maybe just talk through where this piece, the Mary Lanning Regional Network, fits in that healthcare supply chain, if that makes sense.
Yeah, so we oftentimes will talk about that there's 4 components to the healthcare supply chain. There's inpatient services, there's outpatient services, there's physician services, and prescription drugs. And our network that we've built alongside Mary Lanning solves for 3 of those 4 pieces: the inpatient component, the outpatient component, and the physician's component. And again, we've done multiple analysis on every possible network that is available in and around your area, in the Hastings area, and even really throughout Nebraska. And I can unequivocally tell you, this is the best gig in town. This is the best deal in town, on multiple fronts. And I don't want to just always focus on pricing. I want to focus on the long-term impact that this can have on employees, on your population, on their health. And certainly it is. And again, solving for 3 of those 4 components, the 4th component being prescription drugs. But Mary Lanning is going to play an integral role in that, right? Because people that receive prescription drugs are doing so from their doctors. And so a coordinated engagement between the physician and our clinical pharmacy management team is essential to make sure that we are getting best in pricing on prescriptions, that we are identifying misuse of prescription drugs, that we are not prescribing unnecessary drugs, that we have them in the preferred tier as appropriately based. All these pieces work together. And it's important that we have all of them in alignment towards the end goal. And that's what this does, with effectively your business and your leadership of your business in the driver's seat.
Definitely. So we did have a couple of questions come in, Seth, around kind of plan design. So maybe talk through, and again, this isn't designed to get too deep into the weeds on specific, because there is flexibility in how you want to build it for your organization. But maybe just talk through that, Seth, on the flexibility around plan design. And one of the specific questions was, will there be options in there? Can we offer an HSA plan, standard plans? Can we offer a dual option to employees? That type of thing.
Yeah, absolutely. And so the idea that we will start when we're doing our analysis is to analyze your current plan design. We want to compare as much as we can apples to apples from a plan design perspective. So let's say that we take we'll call it a $2,000 deductible plan with an 80% coinsurance, a series of copays, and a prescription drug card. I'm going to talk about the HSA plan here in a moment. So the first thing we're going to do is price out all of the claims if they are available to us. So if you're self-funded, we can certainly price out those claims and understand the cost based on your network contract. The second component of that, though, is then to understand where there's opportunity for more efficient claims utilization and greater access. And so within the Mary Lanning network, we'll create incentives for Tier 1, which is to Mary Lanning facilities, that lower your employees' deductibles, in some cases from a benchmark perspective. And we worked with Consociate Health, who again has done this in multiple areas throughout the country, and they'll be part of this conversation with you, that would reduce the employees' deductibles by half, the coinsurance by half, and the out-of-pocket by half. That is a financial win for you and a financial win for the employee. And then in that second tier, so these are our referral partners because of the contracts that we've secured. The idea is that we'll split the difference there with the third tier, which is the standard wrap network being where your plans are today. So the idea here is that we want these plans to only get better for your employees, and that there's certainly an avenue to do that while simultaneously managing your cost in a more effective and efficient way. The HSA plan has a few different parameters we have to keep in mind. Remember, if it's a qualified HSA plan, we have to make sure we don't disturb the qualified status. So for 2021, for example, an individual deductible can be as low as $1,400 on an HSA plan to maintain qualified status, but that is what's called an aggregated deductible, which means if you have a family, there has to be a $2,800 deductible. And so if you're embedded, that deductible is $2,800 is the minimum to maintain your HSA qualified status. And so we'll want to have a deeper conversation as to what does that mean? Where can we improve the plan and give greater access to those plans to make there a greater incentive for the better pricing and structure and efficiency and effectiveness? And certainly some of the plans that we've already analyzed, we've been able to do just that.
Absolutely. And I think you said it best there. The goal of the network was to only improve on plan design, flexibility, deductible structures. And I think it's just important in this piece to talk through that's the intention of that is so that your employees are going to get the care they need at the time they need it. And that is not that a deductible or a copay or anything like that is not the barrier to your employee getting that care.
Yeah, let me say something to that too, because I recognize that we have dozens of employers on the phone and likely various philosophies for how to manage employees and perception. And there are two really kind of foundational structures, carrots and sticks, right? And we can operate from both. I don't want to say that we can't, but we certainly prefer carrots. And especially if we can create carrot incentive-based programs that yield a better return for you and the employee, right? Because if we can improve quality and access to the employee while simultaneously improving your bottom line, both short and long-term, it's a win-win. We oftentimes will refer to that as the unicorn, but it can happen, and it is happening, and we've done it. So we certainly prefer the incentives-based program. If you're a hardcore sticks person, we can have that conversation too. But I understand that going to employees and telling them where they have to go oftentimes isn't as good of a conversation as going to them and giving them incentives if they will go to places that are going to receive higher quality care at a better or equal price.
Yeah, that's a great point. And so I think I wanted to go back. We had a clarification question, Seth, on again that kind of unbundling piece. And so I think it's important for everybody to know. And again, if you've been self-funded for a while, you're very familiar with this. But this is the network component piece of your healthcare plan. So it's not an insurance carrier that we're talking about here. I think that's very important. And I don't know, Seth, if you want to elaborate on that, but it'd be similar to an independent network like a Midlands Choice or something like that. Just as an example.
I think there are two pieces. So recognize that there are three components to every health insurance policy, whether you're fully insured or self-funded, right? You have your administration, somebody that's processing and paying the claims. If you're fully insured, that's Blue Cross, Aetna, Cigna. You have the network, right, which is who's negotiated the pricing on those claims and how the plan will work. And then you have your reinsurance component or the risk pool, right? And so, that kind of falls into the claims bucket. And so if you're self-funded, you're very familiar with these three options, right? If you're ASO, then likely you're utilizing your ASO carrier, whether that be Blue Cross or United Healthcare or Aetna, for all three of those components. Not really a checks and balance system there, is it? And so, one of the things that the thing that we've mostly been talking about today is that network component. Why? Because that's where all claims begin and end, is in that network concept. It's how access is derived. The administrator, if you're self-funded now, would need to change to consociate. They understand this program. They've managed it. And I will tell you that from a pricing perspective, they are in line and or better than likely whomever you are using now. From a PBM perspective, a pharmacy benefit manager perspective, we have multiple options there. We prefer independent PBMs, those that are going to be as transparent as they are able to be, which is completely transparent. To where we can get the data and understand pricing structures, that we can set the formulary in conjunction with you to make sure that the formulary is to your benefit and your employee's benefit, not to the benefit of the shareholder or the PBM. And then the reinsurance component. I want to spend a couple of moments talking about that. So a critical piece to any self-funded or fully insured plan is what I call the largest legal Ponzi in the United States, or the reinsurance market. This is where we're pooling all of your dollars to pay for catastrophic big claims. Now, if you are on this call today, you are pooled with other employers. No way, shape, or form about it. I'm a former underwriter. I assure you of that. Take it to the bank. Your performance is not solely based on you. It's based on others. And the insurance companies are pooling you, whether you are fully insured or self-funded. You may have your own stop-loss layer if you're self-funded, or what we call a pooling point if you're fully insured, but your performance is not just based on you. Now, one of the things that we have been doing now for many years and have had great success at doing is managing risk pools, managing that pooled layer. So that when we go to market for reinsurance, you're not standing alone. We oftentimes will refer to it as collaborative self-funding, because we're taking your reinsurance model that you want and we're utilizing other employers that have the same philosophies and strategies. And we're doing it not just based in Nebraska. I think that's really important to note. And so our pooled program has right at 1 million belly buttons today. That's 1 million belly buttons representing over 400 million in reinsurance premiums. And the reason it's important to note that is because we oftentimes will call it the volatility buffer protection. Because if you're self-funded, you've experienced volatility, right? And if you are fully insured, you've experienced volatility, right? And so the idea here is that we're able to stabilize that volatility, because if we have a rather catastrophic claim, a large claim, we can spread that claim out over millions lives, over millions of dollars, and it has less impact. And so if we look at an overall healthcare trend in our risk pool that we've launched and had in place since 2015, we're flat. We're actually below flat. We're actually trending just below the flat line. So imagine 5 years ago being able to say, I'm going to be spending less today on healthcare than I am going to for 5 years from now. That's the result that we've been able to do. And that's in large part because, remember what I said at the very beginning of this call, 90% of your cost is generated by 10% of your population. If you're able to do two things, manage the cost and aspects of care for that 10%, and take that 10% and spread it appropriately across multiple lives, you can manage that volatility at a better level. And so if you want to enter into the Mary Lanning Network, you're going to get access to that pool. You're going to get access to the pool that is generating those results and has been generating those results for a number of years. And that's a pretty powerful thing to have in the market.
Absolutely. I'll maybe try to give you a break here for just a minute, Seth. But
I was going off.
Yeah, you're doing good. But no, because we did get some questions around timing and kind of process here, and we did want to make sure that we address that. Obviously, we know what time of year it is, and what time period many of you are in with your current plans. We are ready to start analyzing plans for people, doing the comparison that Seth mentioned. The network is up and ready to go to do that. But again, we want to work with each individual employer on when your plan renews, how your plan is structured, and what options you have available in order to determine what the best time frame is to make this transition, if it makes sense for your company. And because again, those are each a little different. It's different if you're fully insured. It's different if you're level funded, self-funded, and when obviously your plan renews and how it's structured. There are options, even if you're a January 1st renewal, we might be on a pretty tight time frame here, but there are options even of going to a February 1st or a March 1st or something like that, and still keeping you on that January 1st renewal cycle. So we do have options there, and again, it's kind of an individualized conversation with everyone, and we'd love to explore that with anybody on the call if that's something that obviously you're going to run into because you're going through renewal season and enrollments right now. So, but that is something that we're prepared to start those conversations as soon as we can with anybody, so that you can see how, and if you join the network, it could improve the results within your healthcare plan. Anything to add to that, Seth? That piece?
No, I think that's absolutely right. I think every employer is uniquely different in that, I say this all the time, if you're fully insured, your plan actually renews monthly. And so while you may have a policy year that runs on a calendar basis or even a plan year basis, that doesn't mean that you're prohibited from making changes at any time. If you're self-funded or level funded, there's some various caveats to that. So we would just need to look at your contract language to see at what point you could enroll in this. Now, that's not to say that we still can't do an analysis for you, so that you can go into this with eyes wide open and start to work towards a better strategy, thinking about, okay, we want to walk into this eyes wide open and understanding the opportunity that's in front of us. And so I would encourage you, even if you say, hey, well, we've already wrapped up our 1-1s, have a conversation with us so that we can start doing some analysis to see if this is a better opportunity for you beyond 2021.
Definitely. And then kind of on that same notion, we got some questions, Seth, on underwriting information, and we're not going to necessarily dive too deep into that today. But I think a lot of the questions that we end up fielding around this are, hey, I'm fully insured and I don't get a lot of data. I don't see a lot of my claims data. What kind of an analysis can we do, and what does that look like from an underwriting perspective? And so I don't know if you just want to hit on that quick. Again, we don't want to go too deep on this call necessarily, but
Yeah, again, I'll kind of go back to something I said earlier. If you have more than 50 enrolled employees, we can do what's called an indication. And that is, again, I'll share this with you. I'm sure this is going to come as a shock to everyone. Insurance companies are not interested in losing money on you. So whatever the premiums they are charging you, we're pretty confident that there's some profit in that. And so we can reverse engineer your current plan based on your plan design and census and come up with a pretty accurate, we believe, representation of where your money's going. And then the opportunity that could be found within that. And that's if you're over 50 employees, or if you are on a level funded plan, or on an experience rated platform. So that is where we would start. And that's where we can start to do our analysis. And the underwriting really isn't too invasive after that. The under 50 enrolled employee or the community rated market is a little more difficult in that we will likely need to go one of two routes. Either have a better understanding of the known claimants that could be going on, and there's ways to extract that data from the insurance company in some ways. Or we would do what's called individual health questionnaires to get a better assessment and understanding of what risks are out there. Again, we want this to be a good fit for everybody. The pool, the employers that are part of it, but you as the employer as well. And if we can't provide you an avenue for success through this program, well, certainly we don't want you to join. And if you're under 50 enrolled employees and or on a community rated platform, it is more difficult for us to assess the opportunity based on just your current premium.
absolutely. We did get another question here, Seth and Kevin. I hope that I'll reiterate this right so that it makes sense. But Kevin was asking, we're self-funded but have limited to no pre-med assistance, and just was asking if we could define that process a bit more. And Kevin, I don't know if you're on, if maybe you want to let me know what pre-med assistant means, unless Seth, you are familiar with that. But are you?
Yeah,
Is that wellness care potentially? Visits like that. But anyway, Kevin, if you're either unmute or shoot me a clarification on that, we can certainly address that one.
Yeah, Elliot, can you hear me?
Yep, I got you. There you are.
Yeah, I didn't know how to actually define it, but prior to folks having some type of medical procedure, we pretty much are limited right now to leaving it up to the employee to seek out options. Of course, if it's a work comp situation, that's a lot different. But for their own medical, there's not a whole lot of medical procedure assistance with us right now. So I'm just wondering, can you define what that process looks like in a little more detail?
Yeah, that's
definitely.
Great question, Kevin, and thank you. So yeah, you're really talking about kind of during the pre-authorization process or the process that an employee would go through to determine pricing and structure and opportunity and all of that. And this is really where I'm excited about the relationship with Mary Lanning, because this is where the insurance plan and you, the employer, and the hospital system, because this is your plan, are in alignment versus what oftentimes we find now, which is they're in conflict. And so the partnership that we have with Consociate is to manage that predetermination, pre-authorization process in conjunction with both the employee, the plan document as we structure it for you on what you want the plan to look like and do, and then the hospital system. And we've got a direct line of communication with the physicians organization, with the leadership, with the administration. And so that there is a very much an understanding of this is absolutely medically necessary. This is the best course of treatment. And that's one of the things that I was really excited about, and I said at the very beginning, and even Eric touched on it, is that for healthcare to be sustainable or we can get ahead of where the healthcare system has been going in the United States. It's to have a better understanding of the care that we need when we need it, and are there other alternatives or avenues to care, and an alignment when you have the insurance company and you, the employer, and the employee, and the care provider in alignment. Good things can happen there. And so Consociate will take the lead on making sure that that is managed on behalf of the employee. Again, remember, Consociate technically will be representing you, the employer, and that employee. And so it's their responsibility to make sure all those things are in alignment. And they do a phenomenal job of, we'll call it pre-care assessment and review and analysis to understand with eyes wide open everything that's there and what options there are available to the employee.
Absolutely. Thank you for the question, Kevin.
I want to say something here. So I think this is really important. Mary Lanning is in this program too.
Yep, I was going to address that next.
and Eric, feel free to chime in because you haven't said much, but mainly because the guy that's not supposed to be talking has been saying too much. But
yeah, so if I can add a couple of things there, part of what we wanted to build into this plan is a little bit of flexibility, but we wanted to make it more user friendly, if that's a thing, because insurance companies have a habit of putting up as many obstacles as they can between the patient and the providers. Pre-authorization processes are just so onerous, and pre-certifications that might actually be a pre-certification until the claim has been filed. They're like, oh no, that didn't really count, so they deny the claim. And so we've tried to eliminate as many of those barriers as we can, and again, see this as a collaboration and trying to help you as the employer and your employees as the patients access the care they need when they need it based on their physician's medical judgment, and not some guy in an office down in Dallas somewhere. No offense, Seth.
Hey. Pre-COVID, I was in Nebraska as much as I was in Dallas. Eric, do you want to talk a little bit maybe or mention, the involvement that your team has had for your own employees in this process?
Yeah, so obviously since this is the network that we're designing, it only makes sense for this to be our insurance for our employees. And we have made our plan even more robust than it already was. And we've gone as far as eliminating deductibles to use domestic providers, meaning Mary Lanning and our medical staff. And I think the thing here again is, as Seth indicated, you can decide what that looks like with your plan, but should be considering, reducing your deductibles by half. And again, breaking down one of those other roadblocks that sits between you and your employees seeking care where it's really affordable instead of waiting until it's catastrophic. So as an organization, again, I mentioned earlier that Mary Lanning's total spend on healthcare has gone up dramatically. And I know we're not alone in that situation. So we thought if we could find a solution that works for us, it'd certainly be something we can apply, regionally. And again, work in partnership with the major employers in the community who are now the ones writing the check for this care. It's no longer an insurance company. It's the employers. So yes, we are going to be adopting this plan. Obviously, it would be a little bit awkward if we said, hey, here's a great solution for you, but we're not using it. So
as we like to say, we're you guys are eating your own cooking.
For sure.
And that's a great point. And another thing that I want to make sure to, you remember I talked about risk pooling and that it's important who you're pooled with. You're pooled with Mary Lanning. So your experience will impact them and their experience will impact you. That's a powerful thing. So if there was any question as to whether or not this is going to be a good deal, I assure you they wouldn't have wanted to pool themselves with if it wasn't going to be. That would just be counterproductive to the hospital. And so that's an important thing to look at as well. Hey, I want to touch base on the $0 deductible thing because, again, I want to make that a core component of the plans that we review. And when we've done this in the past, we look across the country in working with Consociate is where they've had the most success. It is when we can reduce that deductible to $0. And I will tell you, and I know this is counter to what likely you have been told for years, right? The insurance industry has fed the lie that raising deductibles is the solution here. That is misdirection. It's not. the solution. Remember, 90% of cost, 10% of the population. The vast majority of plans that we review have limited deductible utilization anyway. And so from an employment perspective, from a attraction and retention perspective, the higher the deductible, likely the worse it is and harder it is for you to attract and retain. The lower the deductible, the easier. And what Eric has said and what I will say and what Consociate would tell you, and pretty much any independent mind that has looked at healthcare, and I've been in the business for 20 years, the employers with the lowest deductibles have the lowest cost experience. And that's because their people are getting access to the care they need when they need it. By the way, nobody wakes up today, except for the one or two hypochondriacs out there, and we can talk about them on another conversation. But nobody wakes up today and says, you know what, I think I just want to go in and have surgery. Oh, an MRI sounds fun to me. Have you ever been in an MRI machine? They're not, right? And so we have to break this idea that there is this rampant off the rails cost that comes with lower deductibles. No. Matter of fact, the opposite is true. We're bringing the milk to the front of the grocery store. And the reason we use that analogy is, again, there ain't no profit in milk. And the reason that grocers put them in the back corner so you can pass by all those double stuffed Oreo cookies on the way. I'm giving you my own demons. But nonetheless, the idea is if we can bring access to the healthcare system, get an employee engaged with a provider with the best course of treatment for what's going on at an early stage. Preventative care, early onset treatment, early onset care is a fraction of the cost as later care. And trust me, there are pieces of this that we have put in place that we've worked with Consociate and the hospital to ensure that there is not care wasted.
Definitely. And it sounded like we maybe had a couple folks unmute there. If you had a question, please feel free. We're coming up about 10, 12 minutes left. So we want to cognizant we watch the time, but I want to make sure we get all the questions answered as well. I had one more to kind of close up, but I'll give it a couple minutes as if anybody does have a question here. I think we got most everything in the chat so far, so that's good. While we're waiting, Seth, I guess one question that we've talked about, and I know that I'm sure a lot of the folks on the call probably have as well, is I have employees that are outside of Hastings. This sounds great for those that are accessing Mary Lanning every day, but what do I do about the folks that are spread out across the state or even in other states? Which you kind of talked about the different tiers, but maybe hit on that a little bit more specifically if you've got employees in other places.
Yeah, a couple of things, and I don't want to over analogize this, but if you had a local gas station in Hastings that you could get the price of gas at a fraction of the cost as maybe a Chevron or a Sudoku or something like that. But you say, well, my employees in Omaha or in Paducah, Kentucky don't have access to that Hastings gas station, so I don't want to do this. That's pretty naive, right? You take what you can get where you can get it. Maybe a bad analogy, I don't know. But nonetheless, the idea here is, remember, what we set as the base level is that national network. We're partnering with First Health, which is a division of Aetna, to create a national network that is available in all 50 states. And that is where your plan as it sits today is going to be structured. It only gets better from there based on the contract language getting better, the access getting better, the engagement getting better. And so in the regional areas that could be available, and those regional partnerships are throughout Nebraska. So really we're talking about employees outside of Nebraska that could be maybe not getting access to the pricing structures of the contract language, but they're still getting great access to pricing. Their deductibles don't change because of the national network. Now I'll take that a step further. We have national networks throughout the country for things like imaging, outpatient surgeries, and all of that. Again, a part of our pool is 1 million belly buttons in all 50 states. And so if we have contracts in various other areas, we're going to utilize those contracts for you. So have a conversation with us so that we can take a look and see. But the idea here is that things don't get worse. They can only get better. And they can get better, not just in Hastings and the surrounding area, but throughout Nebraska and beyond.
Absolutely. Okay. I think that is most of the questions we've gotten so far, at least in the chat. If anybody has any other questions, please feel free to either unmute or post it in the chat real quick. We'll give it, I guess, a couple more minutes and see if we get anything that comes in. Oh, go ahead, Brian. Brian?
You talking to me, Elliot?
Yeah, go ahead.
Yeah, we're getting low bandwidth out here, so it's kind of difficult. We may want to address some of these questions. Have everybody feel free to call us. We're getting low bandwidth.
Okay, yeah, definitely. So if it was freezing up on you or was not coming through clearly, definitely reach out. We have recorded this session as well, so we'll be doing some video-based stuff on it as well. So we can always get that out or answer any questions directly after the call, certainly. Any other questions that we could answer?
It's freezing up a lot, Elliot.
Well, we weren't talking there. Is there any other questions that anybody has for us? I don't see anything come through the chat. Andrew, certainly if you got any, throw those to Seth. Okay. So I think with that then, in closing, and we've talked about it several times, so we are ready to run your plans or anyone's plans through the analysis phase, at least to help you determine how your company, your employees would look inside of this Mary Lanning Regional Network. Obviously, as we've mentioned, that is different for every company. It's different on what your goals are, as well as how you're structured today. And so we want to make sure that we're getting you very specific answers to those types of questions, and that you can make an educated decision, obviously, going into that. And so we'll be trying to do as much education around the network as well as we can to continue to get the information out. We understand a lot of people couldn't be on the call today, and so we're going to make sure to keep promoting all of the great things that are built into the network. So keep your eyes out for that type of stuff. With that, I don't know, Eric, did you have anything to close up? Any additional comments?
No, I really don't have anything else to add. I think this has been a great discussion.
Okay. Awesome. Seth, anything from you?
No, I just appreciate everybody's time, and we look forward to having conversations with you, and excited to see where this continues to grow and go as we move forward.
Definitely. Well, your voice held up pretty well. You can go home and take a nap now if you need to. So.
That's up for debate.
All right. Well, we'll hang on here just for a couple more minutes, but thank you, everybody. We appreciate it. Have a great rest of the day, and we look forward to talking to you soon.